Well, good morning, good day, everyone. My name is Mohammad Shukri from Malaysia. I'm specializing in upper GI surgery, dealing with the benign as well as malignant cases of esophageal as well as stomach. And we also manage bariatric and metabolic clinic here in our clinic. I'm very sorry for this setup. We are not well prepared because we are having a busy clinic today as well as endoscopy. That's why you can see I'm using an N95 mask here. Well, upper GI surgery in Malaysia is not relatively new. It has been around for about 2 decades or so. But in the process, we've been trying to actually train more and more upper GI surgeons because this is one of the least subscribed specialty in Malaysia because being so, you have to manage patients who are very, very much well-nourished, either on the cancer end of the disease or the obesity end of the disease. Both of these patients are actually malnourished. And with regards to the perioperative periods and recovery, they are very demanding, and you really need a person or a doctor who is very diligent in perioperative care. So that's why upper GI surgery is the least subscribed specialty in Malaysia. But nevertheless, we've been trying to actually train more and more Malaysians as well as anyone else from the Southeast Asian region who like to actually come over to Malaysia and get trained with under us in this specialty of upper GI surgery. In the past few years, a lot of my trainees has actually resigned from the public service. They are going into the greener pasture over the other side of the service. But to me, that is fine because anyhow, we are still treating patients, we are still providing service to the society, no matter whether you are in the public service or in the private service. All right, now coming back to the actual business that we are running, majority of my workload basically hovers around gastric cancer as well as esophageal cancer. We are at the moment just relocated at the National Cancer Institute. Over the past 12 years, we've been operating and offering our service in another tertiary hospital. But for some reason, because of this COVID pandemic, that particular hospital has actually turned into a full COVID hospital. And that's why in the past 12 months or so, we have to relocate ourselves. It's such a tedious process, but nevertheless, we managed to solve all the problems. And now we are in another center, which is the National Cancer Institute of Malaysia. Now, as I mentioned earlier on, the major bulk of our cases are gastric cancer and esophageal cancer. We have a dedicated team, and we have a specific pathway of how we shall manage this sort of patient. And in Malaysia, particularly if the patient is undergoing treatment under us, we stress the importance of fast surgical access because cancer in the upper digestive tract is very much affecting patient general well-being, especially this is the first passage to your food. And if food doesn't come in, you will definitely lose a lot of weight. And importantly, you will lose a lot of lean body mass, and this will actually affect the overall treatment. Now, in fast surgical access, we would like to actually aim at 2 weeks of diagnosis, and by another 2 more weeks, complete the definitive treatment, either a surgical upfront, surgery upfront, or neoadjuvant followed by surgery later on. So timely treatment is very important, and we must also take care of the nutritional status of the patient so that whether they are having surgery upfront or neoadjuvant first, they do not miss their treatment, and they do not have any dose-related toxicity, and they do not have any kind of delayed or dose reduction just because of, the body is just cannot coping well with the dose of the neoadjuvant. So having said that, once the patient is stable, either stage 2 or stage 3 with neoadjuvant, they will go for surgery, and if possible, we would like to do majority of our cases a minimally invasive surgery. But as you all know, majority of cases in the upper digestive tract malignancy in Asian countries, especially, they come in a very late stage, and therefore only a small percentage of patients we manage to do it as a minimally invasive surgery. The majority we will do an open surgery, and it is a standard here that we do D2 total gastrectomy with D2 node dissection, selectively depending on types of tumor, the histology, and the position of the tumor. Occasionally, we'll do distal gastrectomy with D1 plus node dissection. As for esophageal cancer, again, the similar manner like what I mentioned just now in the gastric cancer, we would like to stage the patient. We stress upon the importance of fast surgical access and timely treatment, and either surgery or neoadjuvant, it has to be timely. Majority of cases is like, unlike in gastric cancer, in esophageal cancer, it's about 50-50. 50% open surgery, 50% completely MIE or minimally invasive esophagectomy. Depending on whether it is adenocarcinoma or squamous cell carcinoma, then we'll either do esophagus, what you call this, Ivor-Lewis esophagectomy or McEwen esophagectomy. Now, in our center, we have the luxury of ICG, indocyanine green, and therefore we've been using this indocyanine green handheld probe to detect the perfusion of the gastric conduit, or they call it conduit, that we are going to use in replacement of the esophagus that is being taken out. And this handheld probe usually we will use it for the open surgery, or if we were to do it in minimally invasive surgery, we will use the laparoscopic equipment equipped with ICG specialized camera. So this will actually help us either to ensure the perfusion of our neoadjuvant is well kept for, and therefore we can minimize the risk of conduit necrosis of ischemia. And in certain cases where the tumor is very early, we can do sentinel node dissection, so we don't have to dissect so much of tissue and unnecessarily prolong the surgery. Now, as in other non-malignant cases, basically we manage bariatric surgery. We have a dedicated team here. Like for example, today we have a very busy bariatric clinic here. We have 3 phases of bariatric appointment. In phase 1, they will be assessed like in any other bariatric clinics in terms of their previous history of their obesity, and then the medical or metabolic diseases, and then their lifestyle, the medications, and the barriers towards why do they develop this obesity. So this has to be assessed. We have in our clinic combined discussion with our dietitian and psychiatrist. Okay. We will teach them 5 principles of good lifestyle, including a certain what we call this exercise regime. And this is a must that they have to do at least 2 or 3 times a day. And then we will discharge them and give them another appointment for about 4 weeks following that. And we are targeting about 5 to 10% of fat reduction. Because in our bariatric clinic, we do body composition analysis, and we are actually aiming at the fat reduction rather than the overall weight reduction. Because sometimes if the patient try to actually reduce their food intake, because this is not the healthy way of eating, they will actually reduce their weight, but they are actually losing their lean body mass. So in bariatric clinic, you must remember, a lot of our obese patients, they are actually malnourished. They are even sarcopenic. They are having sarcopenia in obesity. So meaning that they have a lot of fat, but very minimal lean body mass. So with unhealthy diet, unhealthy and unbalanced diet, they can even lose lean body mass, because the body will try to churn out the lean body mass as a source of glucose production. So you have to actually counsel them a proper way of diet intake. You shouldn't skip your meal. You have to take good proportionate meal throughout the day, and the most important thing, to increase the metabolic rate, because a lot of Asian countries, okay, the cases of obesity is much higher in this Asian country, because not because of the eating habit, it is because of the lifestyle. I mean, we normally tell our patient it's fine if you were to enjoy food, because God have actually given you this luxury of eating. Okay, but it's the thing that you have to eat in moderate, and you have to exercise. You have to increase your metabolic rate. It is the issue of low metabolic rate that causes you to have, you know, poor metabolism, and then you start to accumulate fat. Okay, so 4 weeks down the road, the patient will come back, and we will do another body analyzer, and you will see the aim is 5 to 10% of body fat reduction with a maintenance of lean body mass. In fact, if they increase their weight by increasing their lean body mass, that is fine with us. Now, if they manage to aim this 5 to 10% fat reduction, then they will go to the second phase, which is an intensive inpatient meal replacement therapy with intensive exercise. Now, this is a bridge to the bariatric or the metabolic surgery. Why we do it in the ward? Because we do not rely on the patient if they were to go back and to do their own meal replacement therapy, or in other words, people used to call either very low calorie diet or low calorie diet, because you can't see them, you cannot supervise them, they can have many cheat days. So it has to be done under supervision, because this is very unique to our center. We will admit them 2 weeks prior to the surgery with either low calorie diet or very low calorie diet in full enteral formula. So that means no solid diet. It is a very specific formula that they are reduced in calorie according to the requirement of the body, but we will maintain the intake of the protein as high as 1.2 to 1.3 gram per kg per day. And at the same time, they will also be going 2 or 3 times a day to the gym. Okay, we have a specified regimen that they have to do in a day, and every week in this 2 weeks, they will be monitored in terms of their medication intake, because majority of them, by the first week, a lot of the insulin and the diabetic and medication will be taken off. All right, so it is very important for us to monitor the blood sugar, the blood pressure, and we also repeat the body composition analysis. Now, if they manage to reduce another 5 to 10% of the fat in the 2 weeks time while doing the inpatient meal replacement therapy and intensive exercise, then only we will proceed with the surgery. And we have to remember, meal replacement therapy or very low calorie diet cannot be done beyond 2 or 3 weeks, because your body will adapt to it, and it will sense, you know, as if starvation, prolonged starvation. And if your body senses it as a prolonged starvation, the metabolism will change. You will keep your fat and you burn more lean body mass. And that's the reason why we had to counter that with intensive exercise. And this exercise is very much concentrate on increasing the heart rate, which is very important, and improving the resistance to the muscles. Okay. Now, majority of the surgery is the metabolic surgery. We do laparoscopic root and wide gastric bypass, because majority of our patients are down with the metabolic syndrome. only I would say about 30% that they will only require sleeve gastrectomy, which is just the restrictive way of bariatric surgery. And follow up after this bariatric surgery is 3 monthly after at least for the first 1 year, and then the next year, the following year, it will be 6 monthly. And to us, it has to be lifelong follow-up. Okay, so that is so much about the bariatric surgery. We also offer other non-malignant upper digestive tract diseases treatment. For example, achalasia cardia. We have a dedicated GI lab where we will do manometry assessment for all this mortality or achalasia disease. We also have our 24-hour pH and impedance study for those patients who have gastroesophageal reflux disease, or especially for the atypical ones. All right, and yeah, so basically this is majority of the what our business entail in upper digestive tract diseases that we can offer in our center. Well, it is very difficult nowadays to actually tell your juniors or your subordinates what they need to do, because life and times has changed very much, and the demands, especially depending on which country that you reside, is always different. Okay, and the healthcare system will also dictate a little bit whether you would actually pursue in your whichever field that you are dreaming of, or you would like to go into other branches of medical fraternity. So it is very much depends on your situation. So you have to study your healthcare system, which is the best offer within the healthcare system, and do you have interest in it or not. Okay, so basically all I can say is whether you are into surgical base, medical base, or administrative. And nowadays I think a lot of medical opportunity has actually spring up from the administrative part, including the research. All right, so this is also another part where we need a lot of young budding doctors to develop the interest into this, and there's a lot of requests and future in it. So basically you have to ask yourself which are the medical line that you actually have interest, whether it is medical based, surgical based, or I would say research and administrative. All right, and then look back at the healthcare system. How can your healthcare system help you? Because sometimes the public healthcare system is not offering much, that you have to go into the university setting. Okay, if you have that kind of system in your country. Okay, in our country, the healthcare in the public as well, the university, actually we combine, and we only have one what do you call this specialized committee to manage all these things. Okay, and yeah, so it's really up to you. All I can say is that, to like any other what do you call this, to all my junior doctors, the same advice that I normally give them: do not let time passes you by. By 3 years, okay, in this medical line, you have to decide what are you going to do. So don't waste time.